hello, welcome.
Lovely to be here. Thank you for asking us.
You're very welcome. It will be, I think, just to start with, I think quite a few people might already know who you are, but I would like just asking, who are you both? Where have you come from? And yes, just your sort of history around implementation would be great.
Yeah, well, very briefly, started off as a medic, went on to do some academic work in history and philosophy of science, and got interested in what the nature of medical knowledge actually is. Then went back into public health and ended up in health services research, mostly looking at how people use knowledge in policy, in practice in organizations. And then started to do some research into how people use knowledge in clinical practice, which led to the idea of mindlines, and also subsequently to working as an implementation lead in one of the applied research collaborations, one of the ARCs in east of England. The latter part of that work was very much with Andree from the beginning of this millennium.
So I had a slightly different practice orientation. I'm a nurse by background, a graduate nurse, and I started to get interested in knowledge mobilisation when I took up a job as a specialist nurse for research at DGH, a district general hospital in West London in the 1980s. So I've been involved in researching knowledge use, implementing knowledge, and also teaching about knowledge for the last 40 years. I hope that what we say today is helpful.
I mean, you've obviously been thinking about this for a long time, and I would just love to know, what do you think matters the most, and what really works with getting research into practice?
Well,
relationships.
Yeah.
Right.
It's all about people, isn't it? I think researchers think it's all about research and research findings and the rigor of their research. And of course, all of those things are really important. But if you can't convince people to use research findings or give them the opportunity to mold research findings to their practice so they become relevant, then research isn't going to get into practice unless it comes from on high, unless it's a directive you must do. And sometimes that's actually important and really necessary to do. But where you've got the choice, we will do if we want to, it's a bit more subtle, isn't it? And I think people fail to see the subtlety of it. So it's about people and it's about relationships. And I think that's becoming more, I say, kind of on message or trendy at the moment, that it is about people and relationships.
Yes.
But if they're core, then that takes a lot of investment, both in terms of time and skill, but also in resources.
Yeah.
I wouldn't like to think that when we talk about relationships, we're trying to be all touchy-feely. It's not necessarily. One of the key phrases that we often use is robust critical conversations. And it's the ability to get people to talk openly and critically about their views on what it is that's being implemented that's the key very often, and to get them to talk and to listen to each other about what the concerns are and what they think are the good things about it, and open their ears and their minds to each other's views, and be sometimes very critical, but that's fine. So yeah, it's not about, it's not all fuzzy warm stuff by any means.
Yeah. I mean, we've had Alison Metz on the podcast a couple of times, and she's very involved in understanding how we can research, relationships and trust in implementation. So it's quite it is quite a thing at the moment. Could you perhaps go through an example of how you might, start and carry out that process?
Before we do that, should we give a kind of framework, an outline framework of we often talk about this in terms of the importance of 4 overlapping things that really matter. One is the evidence and the nature of the evidence. So the first thing we would do is to examine whether the evidence is in fact relevant, is robust, is appropriate, and not necessarily just do that ourselves, but with the people who are involved early on in the process. The second thing is the context in which one is working, and you have to understand that context, the inner and the outer context. So in other words, there might be pressure from the centre of the NHS, but there's also stuff going on at local ward level or community level or interprofessional rivalries or whatever it is. You need to understand those things. And then from that, you understand who are the key people as the people, the target people who you're going to be working with, are vital to know about. And then the fourth thing is the method you therefore choose to adopt to work with them. And if you get those four things right, you've got a much better chance of winning. So with that sort of framework in mind, if you can imagine four overlapping circles, Andree might want to pick up an example, throw it at
Yeah,
us and
sure.
see which one we go with.
We call it imaginatively the four circle model, so it should be quite easy for everybody to remember.
I know it very well. I
Sure do.
use it a lot, believe it or not.
And
So I'll flash an image up.
Oh, that'd be useful.
great.
Yes.
Yeah.
And of course, it's not just our work that's formulated that. It's an assessment of the literature and our experience and our talkings with other specialists and practitioners in this field over the years that's led us to that. But we tried it out, obviously, in our work and found that it's, it's reasonably successful. So the first stage of it is sort of, they almost go together. There's a bit about, well, what research is available and what solutions is that research going to bring to the clinical arena? Because if you can't match those, then you may as well just not bother. So there's got to be a kind of push and a pull. So if you like, the people who are needing to change their practice or wanting to change their practice must pull that research in and trust people who are trying to push that research towards them. And that's a really important part about it. So to begin with, yes, make an assessment of the research. In the ARCs, it is reasonably easy because it was research that was in some way associated with the ARCs that we were trying to move into practice. So a kind of melding of those two things. Yes, here's some research findings. Yes, here's a problem that needs a solution. Will these research findings help us in that solution? Really critical. A match. If you don't have a match, maybe not worth bothering with that at the moment, but look for something that is necessary.
And before you carry on, can I just ask, would you involve people in practice in that process?
Absolutely.
Yeah. So you're not making the decision on
this
whether
is already happening in discussions with the
Yeah.
people in the section of the health service or whatever it is that you're trying to.
Do they think it's worthwhile? Does it make sense? Yeah. Do they want it? That's the sort of thing, or yeah.
So part of that process is getting one or two key people as really at the core of this whole exercise. So there's usually some kind of local champion, not necessarily the champion of this new research, because they may have already raised hackles. But you want somebody who's local, who's influential, who understands the situation, who understands the problem, and who's got somehow freed up some time to be able to help you to choose the right people to work with, think about the right way of going about it, and become closely involved, and also pick it up when you've left, because somebody has to keep things going. So part of that initial process of assessing whether this is a goer is to make sure that there's somebody on the ground who you can work well with and who will be able to pick up the pieces and help you put them together.
So this is when the circles sort of begin to overlap. So let's say you've got the evidence. You've obviously, because as an implementer, you're able to critique it, aren't you? One of the skills of implementers is to be able to assess the worth, if you like, of that research. Is it worth putting it into practice? So you've done that. You've talked with people in the context in which you're going to be putting it into practice with them, and decided that, let's have a go at it. And so you begun to understand the context. And one of the things we've always done, and we're probably able to do that because of our position in the ARC, was then to go to the most senior person that you could. That could be the chief executive officer, it could be the unit manager, it could be the senior GP, it could be whoever, the team leader, and to make sure that they were
backing,
accepting, able to give their staff time, and it was something that they would be able to put resources in once we left. If they said no to any of those, don't bother. So you're beginning to get a little bit of a flow chart here, and this is critical in success, because if you're going for the don't bothers, you're not going to succeed very easily. And sometimes I wonder if that's what we do. We don't get, what they call those low-hanging fruit, in management speak, jargony sort of books. We don't seem to go for those. We seem to go sometimes for the very top ones that are going to be really hard to reach. So some early successes is really helpful in helping people trust you in an organization. And then when you've established that, you might be able to go back and do more and more and more. And that is a critical feature. Something I learned in my very first job doing this sort of stuff. If people don't trust you in the organization, forget it.
I think it's important too that one of the principles that we use in any quality improvement work we've been involved in is work with the willing. Don't start by going for the people who are antagonistic, but at some point you have to involve those people. And if you work with the willing and you score an early success, then more people say, oh, maybe there is something in this after all. That seemed to work. Let's see what else we can do. But when you put together the group of people who are going to help with the implementation process, you need to involve those who are against it as well. You need to have the antis in there, the resistors, the skeptics, because they have to be able to put their case, because they're going to scupper it anyway if you don't involve them. And the others have to understand why it is and what the problems are. And 9 times out of 10, if not more, when you get that robust critical dialogue and people are listening to each other, people will appreciate what the problems are and will find solutions to them rather than simply resist or simply push on ahead despite the problems and hope it'll all work out. So getting the right people in the room then, and this is the people circle, is vital. Andre's had expertise in something called communities of practice for some time, and we've worked with that for many years since our early research together. We put together a community of practice of all the relevant people who are going to be involved in the implementation, which is not just clinicians, but obviously patients and service users, managers, commissioners if necessary, and so on. And get them to know each other, to trust each other, to listen to each other, and to have that robust critical conversation.
Yeah.
So we've done a few of our circles then, and then the next thing is once you know who these people are. Once you get them together, you can see what's going to be the best approach to change. So we like small tests of change. It means you can try it out and see if it works before you move on. And it also gives people an opportunity to identify their own success criteria. What would success look like to them? Because actually it may not look as grand as it might to a researcher who is hoping that their findings are going to change the world. So it's important to tailor that to suit the project, the research findings, the outcomes, and the people who are doing that work.
This all sounds quite complicated, but actually it only takes a couple of meetings, reasonably well facilitated meetings, of that group of people to get them to have understood what are the pros and cons of the research that's being put into practice, what the problems are they're trying to solve and what they might overcome, and begin to thrash out an agreed plan, an implementation plan. And when they've got that implementation plan that they've all come together and agreed on, they can start selling it amongst their own colleagues, but also they can set, as Andree says, their own success criteria, so that they'll know if it's working. And then we can try out the plan and start doing the small tests of change stuff.
So
that's usually by the 3rd meeting.
Wow, that's a lot quicker than you might think. Yeah.
And I think that's why the small tests of change and the moving quickly. I mean, when you've got enthusiasm, you don't want to be slow about it.
No.
You really want to work with that positive energy, and there often is. I mean, there's resistance as well, but that can be very positive too, because if people who think it's a bad idea can articulate why, then you can address those problems too. So it is a quick way of doing it. Of course, the slow bit is actually the doing it in practice. How long do you keep it going before you evaluate it? Because again, it's got to be evaluated to see if it's making a change in the right direction, if it's successful, with techniques that are not long and drawn out
or burdensome. And that evaluation is based on their success criteria.
Yes.
So, and then you have to do the bit, well, we're off now, we've helped you, we've facilitated it, we've gone through our model, we've given you quite a lot of sort of moral support, I suppose. and enthusiasm, but we're going. So who's going to move this forward and keep it going so that when we come back in 6 months, you can tell us what's happened. And then you just keep in contact. You just sort of, you're sending a little bit of how are you getting on sort of stuff, keeping people warm.
I think it would be worth, you asked earlier on for an example. I'm going to pick the mental health one.
Yes.
What we found there, we haven't talked much about the context circle. This was a mental health service. I won't get too much detail for obvious reasons, but there was an 18-month waiting list, which was totally unacceptable, which nobody managed to tackle for years. It was really, really difficult. We worked with somebody who really was determined to make this work and to have something happen, and who was keen to introduce a whole new way of organizing the service, which was more or less research-based. I mean, that's another question as to how much does this have to be, what evidence is one basing things on? But this was a system that had worked very well in other places, and there was quite a lot of research support for it. So we chose that as a way to go forward, and it took us, in this case, months to deal with the context, which was a nightmare. For all the staff were stretched to beyond anything that is livable with. A lot of resistance to it, because yet another attempt to sort this problem out, and we're up to our neck already in difficult circumstances. Why do we need something else? So that a lot of work had to go into bringing particularly the key antagonists on board, and yet again to recognize that actually this was the way of finally draining the swamp. That took some time. Actually, that took a year. So when I said before, it's a couple of meetings, the meetings hadn't even started. It took us that long to get things sorted out to the point where we could get the people in the room. And the first meeting was all about I'm going to use the word, what a shitty situation they were all in terms of the way the service was organized. So we put that, we got all that, and we put it to not to one side. We delegated somebody to go and deal with that with the chief executive, and said, okay, we can't deal with that, but we can get something going that gets people to look at this afresh, because it clearly is a problem, and that will enable us to do what they want us to do, which is to get this happening. So you kind of satisfy those contextual problems, and then got into the meat of the actual problem, which was then very quick and easy to get going with the right people in the room. In this situation, because it was mental health and for various other reasons, we didn't unfortunately involve the patients and their families early which is my one regret about that project. But the point is that 2 years later, as far as we understand, things are now we've gone, but things are much more organized and much better, and the waiting lists come down. So that relationship thing of getting the antagonists and the skeptics involved was key there.
And it's not just people, actually, interestingly, it's organisations as well, because they're competing for the same space sometimes. So you have the voluntary sector, you've got the NHS, you've got primary care, you've got secondary care, you've got all sorts of people competing for the same space. So you also got to get them in the room and say, well, what is your space? What's the overlap? And until you've done those really, really basic things, you can't move forward with the actual change.
Yeah. I mean, just for the people listening, what's it like day to day practically like? Because I totally appreciate. So it took about a year to actually get the first meeting. Was that a case of you going there or ringing, or no? How did you?
Ironically, we were kind of, I suppose it's a bit like speed dating, isn't it? When you're an implementation lead, you've got a piece of work and you've got somebody who needs a problem solved. So if you can match the piece of work and the problem solved, then fantastic. So there's a kind of, I don't know, kind of convenience element to it. Once you've got your contact in practice, then you've got somebody to work with. And then they can bring in other people. So you go and you meet them, and you're doing those sorts of things with them. And you're then working up to whom you need to meet in the hierarchy to enable this to happen, all of which are face-to-face personal meetings if you can. Now, we got locked down in the middle of that project, just before our first community of practice, which was fantastic. Utterly fantastic, because that meant we could have more people from a wider geographical area, from various disciplines and organisations.
Who would never have been able to travel across the region to a meeting, but could come to a Zoom meeting.
Exactly. So the difficulty of that is facilitating it, and I speak as a facilitator, because you've got 30 people you don't really know, and you have to get to know them because they've got to trust you by the end of that meeting, otherwise you've had it.
By the way, 30 is huge. Normally we'd work with about 8. But in this, I picked a particularly complicated one as the example.
I think it's a good example. A very good example. Yeah.
So it's about, the first meeting of that was about airing all of these, gosh, it's really hard to work here. It's difficult. We've done this before. Why are you here, etc., etc. And then trying to move forward. And we sustained, the membership quite well during the year then, I suppose, that we met in total in lockdown, because you can imagine it was chaos for real.
Yes.
In the service. So if we could grab any time at any time to meet, then that's what we would do. So that was a longer project than we would normally do. And we never met face to face, ever.
Wow.
The irony of it is, not very long ago, we were cycling back from going out for the day, and we actually met one of the key people for the first time in the road, face to face. It was hilarious.
They're probably a different height to what you'd imagine. If you've seen that, they're always a different height.
So you've got to be really flexible as an implementer or a knowledge mobilizer.
Now, just to give you a contrast, in case people are thinking, oh, there's a year to get it going and a year to have those 4 meetings. Another project we were involved in was over and done and dusted in 2 or 3 months. So it just depends on the context and complexity.
Laura Damschroeder came on, and she's been on the podcast too, and she was saying there was a study that looked at implementation and picked up that actually sometimes the ones that started very quickly, the sustainment was less. And so, I mean, I know a year sounds like a long time, but if that was the context, that was what was needed, and you gave it that much time to actually get the engagement, build the rapport, and then you had the success. But I imagine if it had been pushed through from top down, it just wouldn't have been the same.
Well, that's what had happened on previous occasions, which is why so many were so skeptical, because they'd been here before, not with implementers like us, but with other initiatives, and they'd always run into the sands. And I think it's about 5 years since the last push, which hadn't worked. So yeah, you're right. It's if you get, again, particularly the skeptics, to engage, I should say, in this robust critical conversation and get their views heard and dealt with, you're much more likely to get it happening in the end.
So the starting point, the robust critical conversation, is actually the critical part of it. And then you can just get on and do it. And then it's relatively simple, actually. So once you've decided on your plan, and that's a shared plan, then you're just executing it and evaluating it as you go along and tweaking it. But the robust critical conversation is about, well, what's going to help? What's going to hinder? How are we going to do it? Where are we going to get resources from? Oh, that'll never work because it didn't. So it's an attitudinal shift as well as a knowledge shift, because you're trying to increase people's knowledge about the research findings, about a change in practice. One thing, before I forget, not all research findings should be implemented. That's very important to remember, because researchers do feel, as a researcher, I can say this now, we do feel that our findings are worth implementing. But actually at a practice level, they may not be. And one of the projects that we did actually was in showing that these findings shouldn't be implemented. And that was a tricky project, but actually a very successful project at the end, because we just simply got the evidence, did a little pilot, a small test of change, found it was impossible, and said, draw a line under it.
And the reason for that was there was a top-down initiative. You must do this. We think this is really important. It came from the very top of the commissioning, and all the people on the ground said some said this looks like a really good idea, let's do it, and some said, hang on a minute, this got all sorts of drawbacks. And the more we looked into it, the more we realized that it was that group that were right. So eventually our success was to stop a completely unworkable and expensive initiative from going ahead. A lot of what we're talking about does depend on having somebody in that group, and it needn't be you, the implementation lead, but somebody who has good facilitation skills, who has the ability. So part of pulling together your community of practice, your group of people who are going to work on this together and get it to happen, is to have some people with the skills to encourage and enable that conversation, that critical conversation to happen. People, going back to the old bell bin stuff, people who are able to go away and get things finished and get things done. You need to make sure the group has got the right skills when you're putting that group together. And that's part of understanding the context and the people as you're talking initially with the key person or people that you're going to work with. Make sure the right people are there who can make all this happen, because it's not magic, but it is that there is skill involved, and it needn't be your skill as the person running the project.
But you're the coordinator. And the other thing I think we've learned over the years is that people leave. So if you can identify a couple of people with those skills, so somebody leaves the project, they leave the job, don't they? Then there's not a void. Somebody else will just slip into it. So that kind of helps with the smooth running of things. Facilitation is absolutely critical. How you are with people.
Yeah.
When we give this technique a name, we call it the facilitated communities of practice model, which is a bit of a mouthful, but basically it is about helping groups to work together. And groups often are people with very differing views, and certainly with differing backgrounds, because you've got patients in the room, you've got managers, you've got antagonistic clinicians and protagonistic, if that's a word, clinicians, and so on. So there is a big skill in that.
Yes.
And I think that's important as well when we think about knowledge mobilization. And we often assume that researchers are able to mobilize their own knowledge, their own research findings, which of course they do perfectly well in certain arenas, in the publication arena, in the conference arena, in the social media arena. But some of them are not able to be facilitators as well to really implement their findings. That's not a criticism of researchers. It's just saying researchers would be best, yes, a different job, would be best to pal up with people who they could, work with to help implement their findings.
Yeah.
Actually, before we move on, I just want to say one more thing. When you have your implementation plan that you put together, that is the point at which people with an understanding of the different methods of improvement, the different methods of implementation, which have been shown to work in the literature and so on, that's when that comes in. So our method is not saying you use our method and that's what works. What we're saying is you use our method to get to the point where you can use the change method, the fourth circle, that will be most appropriate in that situation. And then you can go to the literature in this. I'm going to be skeptical here. I don't like the word implementation. Science, I think that's a bit of, hocus pocus. It's a craft. But anyway, the implementation science literature does have evidence on what works, what doesn't work, how to evaluate things more appropriately, and so on. You can apply all of that in the way that you design your implementation plan. We're not saying ignore all that stuff. We're saying use that stuff, but use it judiciously within the context that we've just described. And that's very important, because some people have been resistant to our approach because they felt that it excluded their approach. It doesn't. It creates a space for their approach to work more effectively.
It's like, is it like it's almost like your approach up until that point is kind of an engagement approach. I mean, because I was thinking, is it knowledge mobilization? Is it? I guess you could say it is, but it generally though it's kind of, you're just getting everyone connected, everyone on the same page, making a plan, doing all that.
You're building the road for the knowledge to be mobilized on, if you want.
Yeah.
You're building the pathways and creating the space where it can happen.
Well, it sounds brilliant. I use your model a lot, and I actually think it's also a good model for research, because what I've done is, I've put a fifth. I'll show you this at some point. I put a fifth circle within system learning, because what I'm saying is, when if you understand that these 4 domains are all going to affect the implementation outcome, and they're all interacting constantly and affecting each other, And what I argue is that we want to capture that interaction in a kind of case study approach for each site and pick up that within system learning, which to me is like the practical, how do you implement? And then, so I've been using your model as a way to also not just about how to engage and implement, but to actually do implementation research. I don't know what you think about that, but
yeah, it's great idea.
yeah.
I like it.
It's brilliant that, because also then you're capturing that learning, which you can publish it, can't you? And you can disseminate it in various ways. And that's really important for other people to learn from.
You wanted to talk a bit more about knowledge then itself.
Yeah.
Is that right? Yeah.
I think we should ask ourselves at some point, when we're mobilizing knowledge, what is this thing that we're mobilizing? What is the knowledge? And Andree and I, as you may, well, I know you're aware, but your listeners, your viewers may not be, have done some work in which we try to understand how people use knowledge in practice. And one of our key findings was that people don't use the knowledge as it's come out of the research, the theoretical or canonical knowledge, the stuff that's in the textbooks. What they do is they use something which we call knowledge in practice in context. And people have to be able to access this knowledge in practice in context quickly and accurately in order to get on with their work, which is where our idea of mindlines has come in. We perhaps ought to explain the term mindline. Everybody who's in the clinical world will know that there's a plethora of guidelines. There's guidelines for everything. And guidelines are based on what we know about the clinical practice. But guidelines don't necessarily make a sufficient allowance for the local context and for the particular situation of a particular patient with multiple pathologies or whatever it might be, or particular social and economic circumstances, or with the resources that you have available. The guideline may say do a scan. Well, there may not be a scan within 50 miles. So what do you do? So as practitioners, we build up ways of dealing with these things in different situations, but we can't spend forever thinking about them. They're instantly accessible in our heads as not the guideline that's in the literature or on the screen in front of you, but the internalized guideline that you built up throughout your professional career, which is what we call the mind line. And this mind line takes account of all the different kinds of evidence and knowledge that Andree's talked about, besides the research and besides the official guideline or whatever NICE says you should do or whatever it might be. And that internalized mind line is there embedded in somebody's head. If you're going to try and introduce a new piece of knowledge, a new piece of research evidence in your knowledge mobilization, you've got to get it into that mind line, which is very well embedded and which works. That's how practitioners can get through their work efficiently and effectively, by having built this up, and by building it up in discussion with trusted colleagues, by learning from each other, by sharing experiences. So you've got that to fight against when you're mobilizing knowledge, and you need to be aware that everybody has their mind lines about everything, actually, not just about their clinical practice, about how to handle complex situations, and you've got to work with that somehow.
And the knowledge that we're talking about isn't just research knowledge. I think this is a really important thing when we're thinking about knowledge mobilization. As practitioners, we use lots of different types of knowledge in our practice. We use research knowledge, we use theoretical knowledge that may not be based on research, but is based on logical thinking. We think people also use experiential knowledge based on their experiences of their jobs, of their interactions with people. Knowledge that they have gleaned from their interactions with their clients, with patients, with other professionals. So a whole vast array of knowledge, and research is only one type of knowledge. So when you're implementing research, and I'm deliberately not using the word knowledge mobilization here, when you're implementing research, that research is competing with all of these other types of knowledge. And I think that's something else we don't appreciate. So if the research doesn't stack up, if it's not going to be relevant, or if it contradicts some grounded experiential knowledge, then it's not going to be well accepted. And as an implementer, again, you have to appreciate that your evidence, your research evidence, has is going to compete with other people's knowledge and where they are, their mind line, their kind of state of thinking. Individuals make up organizations, don't they? So you could say that, you're making up the organizational mind line, what you do here in this organization.
Yes.
So again, to go back to knowledge mobilization, I think it's important to work out what knowledge you're mobilizing, moving.
Yeah.
I mean, knowledge mobilization is simply moving it from one place to another.
Yes. Yeah.
How you're going to do that, and how research, being one type of knowledge, is going to compete with the other sorts of knowledge that individuals have in their minds, and
Yes.
how you're going to allow them, enable them, facilitate them to articulate that, and then come to a shared decision, essentially, about what you're going to do.
Yeah.
The knowledge you're mobilizing is the theoretical, canonical, textbook, research knowledge, whatever. But by the time you're thinking about implementing it, it has to have been turned into knowledge and practice in context. And the long process we were or the lengthy discussion we had about our process for implementing is actually about how you turn the theoretical knowledge, the research knowledge, into knowledge and practice in that context. We always use the word knowledge transformation rather than knowledge translation, because the process of embedding the knowledge and practice in context into somebody's head or into an organization or into routine practice always involves transforming that original theoretical knowledge into something slightly different, adapted, made suitable for that context, for that practice, and for that individual case. And it's that transformation process that's facilitated by the facilitated community of practice method we were talking about. And that's a step beyond simple mobilization, perhaps.
Let us show you, if we can find it, what knowledge is.
Oh, hello.
There it is. Okay. Yeah. Now I'm going to pass that on to my colleague to see if my colleague can put it into practice. And she's going to give it to her boss, which is me. And he's going to have a look at it and say, well, yeah, that's okay, but I'm not. Wait a minute. Let me just go and talk to the CEO. And by the time you've finished, it looks like that. But that's the piece of knowledge you're now going to implement.
Wow.
And that's the transition between knowledge as it comes out of the research and the knowledge in practice in context. And we use that as the...
Sometimes we say that implementation is like a pinball machine. Instead of putting in a hard, metal pinball, you put in a bit of potty putty and you ping it around all over the place.
And it bounces between all the different actors.
It is just like this. It's nothing like what you came up with to begin with, or what you had to begin with. It has to change. And that's the transformation of knowledge that John was talking about.
But it's still the same basic stuff.
It's still achieving the same function, right?
Yes.
Because we use that.
But somehow that evaluation, the what it is, what's a potty putty become, needs to get out there to other people. And that's the hard bit, because practitioners are the people who've been responsible for that, let's say, and they may not be the people who have time or skill to write it up. So we need some kind of way of getting those evaluations out there so that the next people to take that bit of knowledge on don't have to start from scratch. And that's again another problem that we face in implementation. We seem to be always starting from scratch.
We need to develop ways of understanding how and why, and accepting how and why it was transformed and why that mattered, so that the next people doing it can recognize what they may need to do.
Yes.
And the obsession with, or preoccupation, I should say more accurately, with fidelity, in a way acts counter to that, because you're forcing people not to adapt it to the practice and the local context. You're forcing people to stick to what was originally said, and that may actually be running against likelihood of it being successfully put into practice. We need to get better at describing what was the knowledge and practicing context that was actually being implemented, and how did that really work in that particular situation, so that people can understand how it relates to their own context.
In whatever way we can, even if it's just simply an audio recording of it, an easy story, that somebody can then listen to.
Well, it's been amazing. Honestly, this is going to be very useful for a lot of people. So much for your time. Really.
Pleasure.
Thanks for inviting us.
Yes, thanks for inviting us. Bye.
You're welcome.